Hi, I'm Mirai, and I'm a policy researcher at the MIT Jameel Clinic.
And hi, I'm Aziz Ayed. I'm a computer science PhD student at the MIT Jameel Clinic, and we're here to answer all your questions about Mirai. So Mirai is an AI tool that we developed here at MIT 3 years ago. And the way it works is that it takes as input a mammogram, and it gives you your risk of having breast cancer in the next 5 years, year per year. And we're actively working towards deploying it in hospitals and having doctors use it in their clinical care, in their routine clinical care. The first question is, how do you know if the cancer didn't develop yet? So that's a great question. We get that question a lot. And it really boils down to the way the model was trained. And to do that, we got hundreds of thousands of mammograms, more than any doctor could see in their life. And in these mammograms, we had patients who already had cancer, who didn't have cancer, but got cancer 1 to 5 years later, who never got cancer. And we really trained the model to detect these subtle patterns that are invisible to the human eye that doctors are not trained to see. And that's where the key difference is. Doctors are trained to look at an image and see if a tumor is already there. Mirai is trained to look at an image and look at these invisible to the human eye patterns and detect if a cancer is going to appear in the next 5 years.
All right, I'll take the next question. What happens in the management of patients then? Are patients able to avoid surgery and start early treatment to reverse? So the whole idea of Mirai is that once you know a woman's risk of developing breast cancer the next 5 years, then we can identify the high-risk populations. These high-risk populations are able, in theory, to come more frequently for screening. And the whole idea of this is, yes, to avoid women having invasive treatments because you can detect the cancer earlier. And so, yes, reverse it. So will it be covered by insurance? Right now, Mirai is deployed in research settings across the hospital network that we're developing, which means that it's not, firstly, FDA approved or approved by any regulatory agencies. It's really for research purposes. So it also means that it's not integrated into clinical guideline organizations or things like this, which allow reimbursement. That being said, if you come in as a patient and get a Mirai score in these research settings, that won't come at any cost to any of the patients. What might come at additional costs is that if the woman's considered high risk, then additional screenings might come at the patient's own costs. Pretty soon we won't need radiologists. It's coming. Not necessarily a bad thing to add more objectivity to studies that often get misinterpreted. So what we really want to emphasize here is that Mirai isn't here to replace radiologists. It's really there to help both radiologists and patients make better decisions and have more personalized screening strategies. So it's really in complement to radiologists and patients for better decision making.
So the next question is, does it only work on breast cancer or other cancer as well? So we're a research lab, so we always work on developing new technologies, new algorithms, etc. And the good news is we have another version of this tool, slightly different, that's called Sibyl, and that's designed for lung cancer, that works on low-dose lung CT scans, and it's as good, even better than Mirai, at detecting if you're going to have lung cancer in the next 6 years. And we have other projects coming. We're working on pancreatic cancer, prostate cancer. We're also working on some kind of new ideas towards early screening. So stay tuned and follow us if you want to have more information in the future.
Yeah. All right, so can we try this now? Can I be a trial patient? I'm told I have some of the most dense breasts ever seen. First of all, I would go on the MIT Jameel Clinic website and look at where the tools are currently deployed and see if there is any hospital that provides Mirai in these research settings to see if that's accessible to you at this stage. If not, feel free to contact your local hospital and also ask them whether this tool could be installed and implemented in that setting. Regarding dense breasts, Mirai has been trained on very diverse population, including women with dense breasts and women with non-dense breasts. And so it works perfectly well across these different populations.
The next question was, where is this available? We're working actively towards deploying Mirai in multiple hospitals around the world, actually. That's what we call the Hospital Network Initiative. And so today we work with more than 66 hospitals in more than 30 countries. But a lot of these are retrospective trials where we test the model and we make sure it works on retrospective data from patients. And today the model has been validated on more than 2 million patients, and it works great on these patients. In prospective usage, the model is still a research tool, and it's really deployed and rolled out in very selected cases in clinical research settings on prospective trials. And you have more information on this on the website of the Jameel Clinic, where you can see really all the details about the initiative, which hospitals is the model installed in, etc. But for example, an example of trial going on is at UMass in Massachusetts, where there's prospective trial going on using Mirai and making and testing its usage in clinical care. And so when I say prospective trials, I mean it's really settings where we have patients come, get a mammo, have their Mirai scores computed, and then they get called back earlier or later, or they get referred to MRI thanks to their Mirai score because Mirai detected that they were at high or low risk. A retrospective trial, on the other hand, is when we get data from patients who came 5 years ago, 6 years ago. We compute their scores at the time and we compare it to what actually happened to them in the next 5 years because we have that data.
Perhaps MRI should be the standard of care in diagnosing early breast cancer. What a shame this is reserved for those of great resources. So countries choose to use mammogram screening as a general population screening strategy for two main reasons. The first one, as it's pointed out, is that it's much more expensive and much less widely available for most people. The second reason is that MRI has a higher sensitivity, meaning that there are higher rates of false positives, meaning more women who are overdiagnosed and who end up having invasive procedures like biopsies who actually don't need them. So those are the two main reasons that most countries choose to go for screening with mammograms.
What's the false positive, false negative, and true negative rate? And so it's a bit of a tricky question because Mirai gives you a probability instead of a yes or no answer. And usually you really compute this false positive, false negative when you have a binary answer. That being said, doctors in the past have been using traditional risk models such as the Gale model, the trial-accusing model that are in national guidelines and that use kind of broad risk factors such as your family history, your age, these kind of things to predict if you should get additional screening or not. When we compare Mirai to these traditional models, what we observe is that we get the same numbers of false positives, but we catch twice as much cancers at least.
Can I ask that one?
Sure.
Aziz, why not just find the cure?
So that's a great question. And the short answer is that in our lab, we really focus on screening and early detection of cancer. There are other people at MIT who work on developing new treatments, new drugs, and that are doing amazing work. Go check them out. The idea is that it's usually longer time scales. It takes longer time to find new treatments, to test them, to try them out, and to roll them out to patients. That being said, early detection is really important, and it can really lead to saving way more lives. When you catch breast cancer when it's still localized, the cure rate is close to 100%. So do get screened, and we're going to push to get Mirai used by doctors and to catch everyone as soon as we can, and catch everyone when the cancer is still localized.
Thanks for your questions.
So by the way, we get asked a lot, what's the price of Mirai, what does it cost for hospitals, for doctors, etc. And something we're very proud of is that Mirai is open source. The model is available for free on GitHub and anyone can download it. You have to know how to use GitHub and code, but everything is online. And there's also all the source code on how to train the model, etc. So if you're a hospital, if you're a doctor, if you're interested, feel free to reach out to us and we'll be happy to help.